start by telling us about your career and how you've noticed since the days of the Brook, how things are different?
It's a long time ago. Well, so I started as a consultant in 1988, so that's a long time ago. And it's 7 years at the Brook Hospital, which was the regional unit. So neurosurgery has always been regional in the UK since the Second World War, really. The units were founded after that very much on a regional basis. So there are 34 units in the UK now. And then in 95, we amalgamated with the Maudsley unit, another unit where I worked as a senior registrar, and formed the King's unit, which is celebrating its 30th anniversary in July. A terrible negativity about these tumours. They had such a bad prognosis. And I remember once a paper, I think it was a Liverpool unit, gave it to the Society of Neuroscience, where they just said all you should do is a biopsy and radiotherapy. So surgery was a bit shunned for trying to do it. But some of us, and I was inspired by the late Douglas Miller, who was a wonderful professor in Edinburgh, who, although a great expert on head injuries, had vision. And he said the future is going to be a big future in tumours and oncology, neuro-oncology. And I think we sort of began the idea of, well, we can do a bit more than just a biopsy. Most of these tumours, we can get rid of a lot of the tumour by surgery. And today now, we've pushed that much further, and we're now getting pretty good resections of tumours, but they're never complete. You can never talk of a complete cure of the malignant glioma tumours, because they have sort of little tentacles going into the brain at deep areas, or they may even occur in the other hemisphere of the brain. But it certainly is encouraged now by most of the oncologists. If we can get rid of the volume of the tumour, that helps the oncology treatments in some way, and patients certainly fare better, probably for two reasons. One, we've got rid of a bulk of tumour in the brain that's causing pressure on the brain, so we can usually deal with that very quickly. And the first measure is to give patients very strong steroids. For some reason, they have a magical effect on relieving the pressure off them. It's thought to have some influence on the swelling effect around the tumours, and stabilising what we call the blood-brain barrier. But that's not a good treatment to be on too long because of the side effects of these strong steroids, and they can be quite disabling in their own right. So if we can get rid of the tumour, we can get the patient nearly off steroids completely very quickly, and then we get excellent specimens, because one of the biggest breakthroughs is now the importance of looking at the molecular genetics of the tumours. And we're very lucky to have a wonderful neuropathology department. I was absolutely delighted that Professor Al Siraj, who I've known for many years, been with us all through my career, has just been awarded an OBE for his work in neuro-oncology and neuropathology. But my other colleague, Professor Ashkan, has been awarded an MBE for his work in brain tumour work and neurosurgery. So it's been very good for our unit. And we do cover about 4 million population for the adults. Pediatrics probably extending up to nearly 6 million. But that's a huge population. So the logistics of managing all the patients with brain tumours are pretty major. And we've worked very hard at King's to subspecialise amongst the neurosurgeons. So we now have specialist team who deals with what we call the skull base tumours, which are in the basal part of the skull around the base of the brain. There are often quite a lot of those in meningiomas and benign meningiomas, or the acoustic neuromas, some with nerve for the hearing, the sort of balance. And then the other group is the neuro-oncology surgeons, who tend to do the intrinsic brain tumours in the brain itself. And meningiomas over the convexity of the head. We do a lot of that work. So all of these things have become complicated. They're multidisciplinary team, and each patient now comes under our neuro-oncology team rather than an individual consultant. And the team, and we really try to place patients with the surgeon who's most appropriate for that problem. So for the lower grade tumours, we have a low grade tumour, and two of my colleagues particularly do those. The paediatric children must go to the children's neurosurgeons. And some of the difficult meningiomas, for instance, I'm often asked to do some of the bigger difficult meningiomas, which are complex sometimes. And that's very good practice, really, and we all luckily are very happy. We're a great team, and during this time, another huge bonus has been the development of the specialist nursing attachment to neuro-oncology. So when I started, one of the great problems is we just didn't have any backup. It's all we were having a consultant doing it and a few consultants, but you need more than that. And getting the backup, and our first specialist, and Vicky was one of our very early ones, and now we've got a super team of nurses who are really vital to the care of the patients. And they had very good understanding of the problems. They can help with counselling of patients, and that's so important. The other thing is that many of these tumour patients have lots of other social problems. It's a devastating disease for the malignant gliomas. And there are lots of issues. They may need help with all sorts of things. Driving is often a big disaster because you lose your license, this sort of thing, if they have surgery, because of the risks of epilepsy. And the classification of the tumours has become very complex as well and revised. So there's a new World Health Organization coding, and that's really now geared towards the genetics of the tumor and the way they've developed and the cell lines. So we're looking much more to a more aggressive and progressive oncology management of the tumors and looking at the really the basics of what's wrong with these cells. The big problem with the malignant brain tumors is the cells themselves are very disarrayed. So they're not a nice, relatively simple line of abnormal cells. They're very complex cells and lots of things wrong with them, and they're very aggressive. So that's why it's one of those Cinderella tumours we're really struggling still. And sadly, people might think, well, what are you doing? Nothing's happened in all these years. An awful lot has happened, as I've tried to highlight. The management is absolutely superlative in some respects. It's very quick. Patients are not waiting. They're very quick. Within 2 weeks, everything's all planned and off they go. We get them in for surgery, but you can do all the best you can. But the thing that gets them is the nature of the beast, and they're very difficult to deal with. There are little windows of hope. Some patients with a little bit better surgery, more aggressive surgery, not being sort of written off, oh, we can't do anything. You begin to get wind with some, and the prognosis are just improving in certain groups. We also recognize from the genetics of the tumour that there are certain groups will definitely do better. So we can predict a little bit better whether they're going to respond to chemotherapy of various types. Therapy is probably where we'll move. We were involved in a multi-centre trial, which Professor Ashcan was the European sort of head of the trial with the American company that were producing a vaccine, DC vaccine. That had some great hopes. It's still under sort of evaluation, the results, and not really openly available because there's still a bit uncertain. It's not a sort of complete magic cure, but it just shows there's a hope and there's a lot of interest in that. And I think understanding the biology of the tumours and the genetic behaviour and what's going wrong in these cells is the way forwards. It might take many years, but there's a lot going on. And it's not just neuro-oncology, it's across all cancer. And that's where I think things will change in the next 10 years. And so we just continue the fight. I think the charities, the patient groups have been fantastic, and they're very enthusiastic and doing the very best they can for a very difficult group of patients. I've always said one thing that is very hard is, and not thankfully having suffered this, but I've always felt great pity for the patients, because if you have a tumour outside your brain, you can somehow, to me, dissociate it. It's in your lung, or it's in the breast, or somewhere else. But if you've got a tumour in your brain, affecting your cognitive abilities gradually. I think that's very hard for patients and very hard for families too, relatives. And patients' cognition and their intellect may subtly change, or their mood changes. And this is really hard to deal with, and desperate. And so it's a they're a real challenge. And my younger surgical colleagues are doing lots of clever things to try and improve our ability to resect the tumours as much as we can. And in the last 10 years, one of the great changes was the use of a fluorescent dye type of technique with Gullan, which, when we put it under blue light, shows a pink fluorescence. So you can see any bits of the malignant tumour within the cavity if you've removed a tumour, and it lets you just take that little bit more if you think it's safe to do so. And so you're getting better quality resections. Is it making a huge difference in the result? Well, not massive, but it's just edging a little bit more. And there's always the odd patient, and you should always keep that hope. There's the odd patient seems to just get through. Like, one can't quite understand. We review the histology, review it, and say, yeah, well, it's definitely a very nasty malignant, but they're still alive and they can be up to 10 years. And I've had one or two patients who've gone for many years, and it's remarkable. And I think Vicky, we've known one or two over the years. So there's always a ray of hope. You never say never. But I think there's an awful lot of care in counselling people, and care is very important. So not only is it the aggressive management of the tumours, which we will be very aggressive as we can in our unit. We tend to be very proactive and keen to do the best we can, but also you have to know when the chips are down, when you're not going to win. And there's nothing worse than people being sort of flogged to death, if you like, by treatments that are really to no avail, when what they need is care and help for their loved ones and time, because we're all limited in our lifespan. And as my old chief used to say, we're all sadly going to die at some stage. It's just when. And I think it's very important that quality of life is important. So we're looking very much, and I know Vicky, you've done a lot of work with the onco specialists on quality of life, and that's very important. And also the role of palliative care and the smooth transition from what we would call active oncological care to palliative care. And that's very important, very important.
And this is, I think, one of the things that have been highlighted by the charities, as you mentioned, that the focus isn't just on the treatment, because we know, sadly, that we're not in a position to have the answer for the treatments yet, but people are working on it. But there's a lot of work still to be done. And so it's very important that the multidisciplinary team, the physiotherapists, the occupational therapists, the speech and language therapists, they're all working to optimise patients with malignant tumours' health, because the quality of life is so important, but they need the rehab in the same way another tumour type needs the rehab to live their best days.
Absolutely. And that is important. So as I said, it's not only just specialist nurses, it's the rehabilitation. Speech and language is a big part of tumour problems sometimes, especially if it's what we call the dominant hemisphere, usually left-handed side tumour in the patient will affect their language function very badly often. And so they need help with that and how to communicate. So they're often sort of gradually like a very slow progressive stroke for some patients. You've got to manage this as it happens. I see we should always be positive and enthusiastic, but medicine is about care. And so there are lots of positive things, huge change in my career. I think the UK system of the MDT and is really world leading. I've gone to enough international meetings to know that they're still at that stage where people tend to be kept by individual surgeons, don't really want to hand things over to oncologists. We're blessed in a way by the uniqueness in some respects of the National Health Service. There are many things wrong with the NHS today. There always have been ever since I qualified. Everybody said, "Oh, the NHS," but But in a principle, one of the greatest things is that the doctors are salaried. So there isn't an incentive to do operations because you're going to make a lot of money doing the operation or giving the treatment. The incentive is to do what is hopefully evidence-based, really good quality care. And I think the MDT system we have today is pretty hard to beat, because what it has done, because all the units in the UK are doing this now, is it's evened out care. So you don't get these extreme viewpoints, which is never good management. And so most units are all doing this, going along the same sort of principles. And we have very good relationships with our adjacent units or other units. And sometimes we're asked to do a second opinion for an MDT or a case they're a bit worried about. So what do you think? Should we do this or shouldn't we? And there's lots of cooperation. And so that has allowed this to happen. And when I speak to my trainees from abroad, or some of the European, oh, they would never do this. They would never let somebody else treat their patient. They would always want to operate themselves, even though they might not really be the most appropriate surgeon. And so because there are enough of us in our unit and we're all subspecialised, we tend to cross-refer absolutely freely. That won't happen in an individualised private system. We do have a team privately we've done and experimented, which has been very successful, but it's very hard. And so I think the NHS for this sort of work is really a lifesaver. Of course, you can get special treatments and maybe one or two medications have not been approved by NICE or whatever, and they're very experimental. I think all of us should warn patients, be very careful of overzealous activity to do that. I think if patients are going to have some new drug that really is right at the front line, they really should be in a trial. They should be in a proper clinical study trial. The individual just prescribing it because it may have worked and this is all gee whizzy, it's a dangerous pathway to go down.
And what would you recommend, Mr. Gullan? So I think it's fair to say that often people diagnosed with a brain tumour can be quite vulnerable because we don't have the answers with the treatment that we have, and we're very open about that, which is why for us we encourage second opinions, and if people want to explore other options we would encourage them to speak with us about it, so that we can support and advise and work alongside with them. What would you say for people who are thinking about alternative options or seeking second opinions?
Well, I think you should, firstly, it's very understandable to seek anything. And any patient with a brain tumour, everybody knows if somebody's got a brain tumour. For some reason, it gets around the community, oh, he's got a brain tumour. Because it's a bit different. It's a brain tumour. He's got a brain tumour. If somebody's with breast cancer or something, they're not going to say, oh, we've got breast cancer. You know, it's different. She's got cancer. But a brain tumour, it's a brain tumour. It's a brain cancer, actually, but for the malignant gliomas. But I think it's very understandable for friends and colleagues and oh, I've heard about this wonderful treatment. I've heard about this. And everybody's doing it because they want to help. They do anything to help. And the patient, of course, is vulnerable because they're desperate, because what's available is a bit limited. But we would always tend to favour you should go through the really well-established treatment first, because that has been shown to work. So radiotherapy does improve survival. Certain chemotherapy drugs do improve survival. This has been proved in huge clinical studies and trials. Surgery, interesting, has never really had a definitive trial of no surgery versus surgery. But all of us know in our heart of hearts, and all of our oncologists agree, and they wouldn't agree unless they thought they're pretty serious about these things. Most medical people don't like surgery unless you have to do it. But they would all agree that surgery is really good if it's done for the right reasons at the right time. And it's usually at the early stages of dealing with the disease. And of course, it's very important for getting a proper pathology and knowing what you're dealing with, because that can have major implications on subsequent management and oncology. Once a patient's been through what we call the standard regime of treatments, our own oncologist will then look towards possibilities of slightly more marginal borderline medical treatments or drug therapy or a change of chemotherapy regime. And that's their specialty, and they're always happy to discuss it. And then there are one or two drugs that are floating around, are massively expensive, that have been proven to be good in, for instance, breast cancer or some certain field. And it's very easy to jump to the gun and say, oh, well, it'll help the brain tumor. Well, they may or they may not. And this is where I do stress the importance of this sort of treatment should ideally be in a proper specialist trial. But if patients are having, there are all sorts of other ancillary therapies. People have been looking at cannabinoid oils, and one of our specialist nurses did a study on this with our patients. And in fact, many of them were on it. They didn't admit to taking them. Well, I think if as long as they're not doing harm, they may be doing a bit of good. It's not easily proven in a ruthless clinical trial, which is proper statistics and looking at outcomes properly and complications. But as long as it's not some reckless sort of racketeer sort of thing, I see no harm. If it gives the patient the feeling they're doing something, the family feels, well, they're doing something, they're trying this. People have ideas about diet and everything. Well, I think my advice is always eat what they like and have a nice diet and enjoy their food, enjoy their life, because life. And my own advice to most patients is go with your team, your oncologists, and hopefully you trust them that they're doing the best they can, what they think is in your interest, especially with the specialist nurses who you're attached to, usually named with a named nurse within the team. And try and lead as normal a life as possible. And the other thing I always try and encourage is that the patients, especially in families or with partners or spouse, you can sometimes get a phenomenon which I call a sort of glass screen between the husband and wife, or husband and wife. The wife knows he's got a tumour and it's bad news. He knows he's got a bad news tumour, but he doesn't want her to get upset, and she doesn't want to get upset. So they don't talk about it together. And we see that with the charity work and the amount of support from families who've had a loved one who's unfortunately suffered a brain tumor and died, but they continue helping in the quest for brain tumor patients. It's fantastic and much appreciated. So I think that we have to look much more holistically at the problem, not just entirely just at the gym, but at the end of the day, if you say, well, what do you want there? I want a cure. That's what we're all after. We want the cure. We're not interested in, well, a few years. We want a cure at the operation. And that's what people, of course, with a brain tumor, they want, no, I don't want to be improved for another 2 or 3 months or years. No, I want to be cured. Well, we all want that, but we're working towards it. But I think it's sort of that's in the realms of pure science research, neuroscience research, and cancer research. But things are happening and they're very positive. Funding is always needed. And, the demands are for everybody wants funding for everything. But I think, thankfully, brain tumours are perhaps moving a little bit away from that dreadful Cinderella stage they were at when I started, where they were just almost ignored, and now they've been come right up into high profile. One or two, Tessa Jowell case was one or two high profile people can often make a big difference. And we're quite privileged to be recognised as Tessa Jowell Centre of Excellence for Brain Tumour Management. And we've all worked very hard for that. And we're very, very proud of that and trying to do our best. keep that standard.
Thank
So-
you. And I think for the for this month, as Mr. Gullan said, you know, we are also focusing on support. So there is a carers support group that is running this month, and there's various different webinars trying to support people and look at holistically what else we can offer and what we can advise. So please do keep an eye out for those. But thank you very much, Mr. Gullan, for joining us and for sharing your wisdom.
Yeah.
It's very much appreciated, and I know people will really enjoy listening.
No, keep your spirits up, keep your spirit and keep going. All right.